Hi students, I wanted to bring together a discussion of epidemiology with our earlier discussion about the social determinants of health for today's class session, and to do so in the context of looking at our current crisis with the COVID-19 pandemic. And so this is part one of our lecture on flattening the curve, the social determinants of health, and framing our current crisis. So just as a reminder, the disease itself is called COVID-19. The pathogen is called SARS-CoV-2 due to its genetic and molecular similarity to the other pathogen that we generally refer to as SARS, which had quite an impact in 2003, predominantly on East Asia and Southeast Asia, but then also spreading into Toronto and other parts of the world. This is a novel coronavirus that we're seeing in SARS-CoV-2 that hasn't previously been documented because it's a new coronavirus. It is something that no one really has immunity to. And so it's experiencing, we are now all experiencing, its exponential spread globally within the immunologically naive population that's now being exposed to it for the first time. We're seeing sustained community transmission in the United States and elsewhere, and that transmission is via respiratory droplets and fomites, so both through coughing or perhaps sneezing into the air, although predominantly coughing is a characteristic symptom of the disease, while sneezing is not to the same extent, and some limited persistence of the pathogen in those respiratory droplets once they land on surfaces for some amount of time, especially on smooth surfaces where they could subsequently be picked up by somebody's hands and then brought to their face and encountered in that way. There's also some degree of secondary fecal-oral route transmission, but predominantly it's through respiratory droplets that are then subsequently either inhaled by someone or come into direct contact with those droplets during the cough, or come in contact with the virus within the droplets once they've settled onto surfaces. So you've heard a bit about flattening the curve. I previously posted about it on the Slack, and I'm sure you heard about it in other contexts as well. And so I kind of wanted to address just what that curve is. Let me get my pointer turned on here. So what we see in settings where there is not an adequate implementation of protective measures for disease spread is a spike that can exceed the capacity of the healthcare system to care for people that are infected with the disease. In this case, we can see that through not having adequate ICU beds or mechanical ventilation for all individuals who need it. I do want to remind you that most people who contract COVID-19 will not need intensive care in a hospital setting, supplemental oxygen, mechanical ventilation, and so forth. But somewhere in the range of 14 to 19% of COVID-19 sufferers do require hospital care, with about maybe 5% in total being severe cases that require mechanical ventilation. Should the number of infected individuals exceed the capacity of the healthcare system, those individuals are going to be at significantly increased risk of mortality, even if the response that their body has mounted to the disease might have been adequately addressed had the resources and the healthcare staff been available to support that. And so simply by flattening the curve, you're smushing that hump to bring it down, to distribute it more over time. And then most projections actually do show flattening to also result in a total overall decrease in the number of infected individuals. But the emphasis really is on not exceeding the threshold of what the healthcare system can care for. It does, by necessity, extend the life of the epidemic by flattening the curve, but it makes it much more likely that people who contract the disease will be able to survive the disease than might be the case without the protective measures in place. There are, however, a couple of important sources of uncertainty in this. One is that the healthcare system capacity itself is an estimate in terms of the number of open beds, ICU beds, and ventilators. I'd also consider healthcare staff as an estimate within that, where those capacities can fluctuate over time. One key example is that as healthcare staff become themselves sick with COVID-19, because we often see healthcare workers and other hospital staff being particularly vulnerable for obvious reasons during outbreak scenarios, that will be something that negatively impacts healthcare system capacity. As additional supplies, personal protective equipment, respirator valves, and so forth can be produced over time, we could see some modest increases in healthcare system capacity above what we currently have, but there are a lot of stopgaps on those increases due to just simply the nature of production, and then also some changes that have been put in place as a result of the kind of intensive demand that we're seeing now. The number of infections also is an underestimate, and I think that's important for me to highlight again. In the United States, which has 331 million people, we're only testing hundreds to thousands of people per day. The number of people that are being tested in the United States has increased over the past several weeks, but it's still a lower number than we would need to see in order to really get a handle on the size of the epidemic. And we know of numerous cases of people who are symptomatic who have been unable to receive a test because of scarcity. Globally, there are a lot of mild and asymptomatic cases that are not counted and that are potential spreaders of the disease, despite not being themselves recognized as having contracted the disease. That varies a bit from setting to setting. Some countries, notably South Korea, have taken a more aggressive approach towards testing, whereas some, notably Italy, have not. So there's a historical precedent for flattening the curve that I think is really important for us to understand in terms of addressing why this approach of trying to bring down the peak number of cases at any one point in time can be a real benefit to the population. And that comes from the 1918 influenza epidemic in the fall, and how Philadelphia went forward with plans for a big parade that 200,000 people attended. After there were documented cases of influenza at a nearby military barracks, and after it was becoming kind of obvious to the community that this wasn't routine seasonal flu, but this was, in fact, something more than that, with a higher risk factor for everyone, really. So Philadelphia went forward with this parade with large numbers of people assembled tightly in the streets, all celebrating and cheering together. And 3 days later, after this parade, there wasn't a single unoccupied hospital bed in the city. Philadelphia experienced a very sharp increase in the number of cases and the number of deaths immediately following that parade. We see a very different scenario happening in St. Louis right around the same time. 2 days after the first cases were documented in St. Louis of people that appeared to have this new form of influenza, city government officials swiftly moved to close schools and businesses, to prohibit gatherings of people more than 20 in number, and by doing so, really kept the death rate attributable to influenza in St. Louis much lower than what we saw in Philadelphia with this sharp peak. So I've shown you a couple of these maps before. I just wanted to give you an update today. As of this morning, we have just under 400,000 confirmed cases of COVID-19 globally. We know that the true number is higher than that, and we don't know exactly what it is, but it's still quite substantial increase in terms of the confirmed number, and that's because we're seeing exponential spread, with the number of cases not increasing arithmetically, but really increasing multiplicatively as each person gives it to other people who then also give it to other people, and so it builds exponentially over time. We do still see that globally some of the biggest hotspots for COVID-19 are in East Asia, in Europe, and growing so in North America. Looking at the United States in particular, among the 48 contiguous US states, we see this distribution with a few different population centers, most notably New York, highly affected by the disease. Still see some concentrations around Seattle, where the first cases were recognized in the United States. San Francisco Bay Area, where cases were subsequently recognized fairly shortly thereafter. Also, significant spread kind of in Boston and through the Northeast corridor. If we look at the trajectory over time, we're basically looking at how fast the disease is spreading in different areas and whether there's really indications that this is spreading out, flattening the curve, if you will. What we're seeing is that, and this is graphs on a logarithmic scale, is that the United States in this pink line here is showing a trajectory that's really similar to Italy's without a reassuring flattening out of the curve. There are a couple of points here where you see some flattening. Those are artifactual as a result of reporting and not just showing an indication that there were no new cases for that day and then a sudden leap. But we're mostly just seeing this astronomical rise relative to Italy, which is one of the places that we know has been overwhelmed by the disease and where the hospital system has not been able to keep up with demand. In terms of the rise across the US states, we generally see that among those states that are most affected at this point in time, that they are all pretty much continuing to rise, some a little bit more steeply than others. Massachusetts is kind of a little middle of the pack for these more affected states. It early on was the fourth most state affected, but now has flattened its curve perhaps slightly, but we'll have better evidence of that in the coming days and weeks. And it is still increasing exponentially in all of these. These figures are from the CDC update. This was yesterday's CDC update because today's is not quite available yet at the time I'm making this video. And the numbers themselves close out at 4 p.m. on the day prior to recording. And so these numbers are actually from March 22nd. But I point this out just to show that we now have reported official cases in all 50 states, District of Columbia, Puerto Rico, Guam, and the U.S. Virgin Islands. And we are still tracking on the national level the source of exposure to COVID-19. Previously, near the beginning of the outbreak, there was a lot of focus on recent travel, particularly travel to China or South Korea, as potential sources of exposure. However, now we have a significant majority of cases that are under investigation in terms of their source of exposure, which will overwhelmingly be attributable in the end to community spread rather than to importation of cases from outside of the country. This is an epidemic curve. It is a really classic, simple tool in epidemiology that's often used to try to trace the source of an outbreak or how it's progressing over time. And so it's plotted as a histogram that shows the number of new cases that are reported by date of illness onset. We see this pretty consistent rise from maybe early mid-February through mid-March or so. Currently, we're seeing what looks like a downslope. However, it's really important to recognize delays in reporting impact this. And so illnesses that began during this time may not yet be reported. And we should expect for these bars for, mid-late March to rise in the coming days as people who have been experiencing symptoms have their symptoms become more severe, seek treatment and testing, get a test that in some cases takes 1 to 5 days to analyze, depending on which method and which lab is running the test. and then have those reported back to health authorities. And so I would not say that this is indication that yet that the disease is going to any sort of a plateau in the United States, but it does let us kind of model through how it's rising over time. Within the US, again, we do have diagnosed cases in all 50 states, as well as a number of territories. We have some areas that are much more affected than others, notably New York and New York City, which has a significant fraction of all the cases in the United States. We still see higher rates in Washington and California relative to most of the states, and those were the two that were implicated earliest on in the crisis. We've also seen a really rapid rise in New Orleans over the past week. It's been a big concern. So I'm going to bring this kind of basic epidemiological framework into a place of addressing the social determinants of health. And we'll pick back up here for video part